For all those who have not joined in last session, uh, sir, can you unmute? Yeah, please unmute, sir. I have changed the settings.
Yeah, hi. No, no. Yes. Okay, can you see the screen?
Yes, yes.
Okay. So we are all covered. Nitin, you want to start?
Yes, sir. I would like to welcome Dr. Maninder once again to take second session of respiratory physiology in critical care in pediatrics, and we will be covering important aspects. We will be restarting from the previous conversation which we were doing, and Maninder sir, please give a recap, quick recap to all those who have not joined the last session, and then we will proceed with present day presentation.
Okay. Okay. One second.
So your screen is not visible. Yeah,
Yes.
yeah, it's visible now.
Okay, so we had covered almost 68 slides. Uh, so yeah, are there many new joinees or
Sir, let us start from this because that the last presentation will be shared and
correct?
the talk will be shared, so they will cover it up.
Correct. So hopefully everybody has just gone through the talks. So again, I'll start. You can type in the chat box. The first blue one, what type of breath do you think it is? It's a quick revision that I want to see what you're typing. The blue box, what type of breaths it is, and the red one, red circle, what type of breath it is. Start typing in the chat box. So I know that you have understood a bit. So this is the flow in the first one, and this is the flow in the second red column. So which one is a pressure breath and which one is a volume breath? The chat box is open actually. If you can type, then it will become more interactive. So I just want to know which breath is which. Which one is a volume breath? Which one is a pressure breath? Any one response would be good. Okay. So somebody has answered it and she has answered correctly. The first one is a volume breath because it's a constant flow. The flow is constant. Whereas the second one is a decelerating flow, which is a pressure breath. So somebody has read about it. It's good or they remember. So that is how we define constant breaths, and that is how we define the volume breaths. Now there's something called as a driving pressure. Now, what is a driving pressure? Uh, if you can see in the last time we discussed something called as the peak pressure, which is the total pressure which is there in the circuit, which includes the airway pressure, trachea pressure, alveolar pressure, chest wall pressure. And there's something called as a plateau pressure. Plateau pressure is the pressure which is there at the end of alveoli. So it's a alveolar distending pressure. And there is something called as the PWP, which is the pressure which is remaining constant throughout inspiration and expiration. So it's like a baseline variable. It doesn't change. It is what you have set already. So the driving pressure is the difference between the plateau pressure and the peak. So the balloon or the alveoli, it deflates to this level, then again inflates to this level, deflates to this level, again inflates to this level. So this is the driving pressure. If this driving pressure is becoming more inflation and deflation, that is rapid alveolar expansion and collapse, race phenomena, that will cause alveolar injury. And that will lead to something which is called as the biotrauma. Now, you have heard the term atelectotrauma. That is basically because if you apply no PEEP, the lung or the alveoli will collapse. Then there is something called as the barotrauma. That is because of excess volume that you give, it causes a pressure difference. Then volume trauma, that happens because of the pressure difference, which causes excess volume. And there's something called as a biotrauma. Biotrauma is because when the alveoli get distended up to a particular limit, then they will release the cytokines. And these cytokines will further cause damage to the tissues and also cause damage in the other organ body parts. So eventually the patient would have started with a pneumonia, would have gone into ARDS, and then would go into a MODS. This MODS, why they enter into MODS is because of the uh, biotrauma that happens in ARDS. So you have to understand that now the concept is to limit this driving pressure. That is the difference between the plateau and the peak. If we limit it, then we will not cause the rapid alveolar collapse and expansion injury that causes the biotrauma. So this is what we are trying to say, that keep your plateau pressures less than 30 and keep your driving pressures less than 14. So this is what you have to, actually a patient has to work. This PEEP is a baseline variable and this is the plat. So if the alveoli works in between these two, and if the difference between these two is kept less than 14, then the alveoli which are already damaged will not get damaged further. That is the importance of understanding something which is called as the driving pressure. Now over here, if you can see, we have this patient with an FiO2 of 90%, PEEP is of 6, tidal volume is 90, and the respiratory rate is 24, whereas the monitors show where the FiO2 of 90, saturation is 92, plateau pressure is quite high, it is 30, PCO2 is high, 58. So this is now how do you want to optimize your PEEP? Now, the problem with PEEP is once you keep on increasing the positive end expiratory pressure, now this pressure is going to harm the venous return to the heart. It is not going to cause the blood to go into the heart, and that will actually be problematic and it will cause a fall in blood pressure. So when a fall in blood pressure happens, the alveoli will not be properly perfused, though ventilation might take place, but perfusion will not happen of those alveoli. So VQ matching will not happen. It will cause VQ mismatching. So once you're titrating PEEP, it is important that you maintain the blood pressure, because once you're increasing the PEEP, the ventilation will improve. But if the perfusion decreases, then there's no point of improving the ventilation. So that is what we are trying to tell you, that when you're optimizing PEEP, make sure the blood pressure does not fall. And the second thing is, when you increase the PEEP, saturation should definitely will improve, but the CO2 should also fall. If the CO2 is not falling, that means we are doing something wrong. So this is one just strategy, how to titrate a PEEP. Suppose an infant is here of 10 kg. Now at 1 p.m. we for 10 kg, he was receiving some 90 ml. It's quite a high tidal volume. PEEP was of 6, plateau was 30. The driving pressure, which is the difference between the plateau and the PEEP, is 24. Normally, it should be kept less than 14. So if it is 24, that means this alveoli is expanding to a large volume and then collapsing again, then expanding, then collapsing. It is causing a lot of biotrauma. FiO2 requirement is high, compliance is 6, EtCO2 if you see is 36, saturation is 90, and BP is 110 by 70. Now, at 1 p.m., we decrease the tidal volume, because once you're managing ARDS, you have to decrease the tidal volume, which is called as low tidal volume ventilation strategy. You don't give high tidal volume, but you give low tidal volume. So from 10, we brought it down to 60. From 90, we brought it down to 60 for 10 kg. So we increase the PEEP, because if I just increase the PEEP from 6 to 8 and don't decrease the tidal volume, my plateau will definitely increase. So now when we have decreased the tidal volume, the plateau will fall, because my total exposure of the alveoli is now only to 60 ml. Earlier it was 90 ml. So my plateau has fallen, though my PEEP has increased, because I have decreased the tidal volume. Now if you see the difference over here between the plateau and the PEEP is 26 minus 8, it will be 18. So FiO2 I'm able to bring down. The respiratory rate is still the same 24. Compliance actually over here is improved. And if you see, EtCO2 has risen. Now this EtCO2 has gone up. Why? Because my tidal volume I have brought down. So when I decrease the tidal volume, it is expected that ETCO to increase. It does not mean my compliance has not improved. It does not mean we are doing something wrong. It is an expected phenomena. And the saturation now is 92 and the blood pressure is stable. So what do I do further? Because I have now a plateau which is 26, I can go up to 30. So I increase the PEEP now to 10. I do not decrease the tidal volume. So my driving pressure over here becomes 26 minus 10, which is only 16. So I'm coming down on the alveolar overexpansion that is going to happen. And my FO2 is still falling. It is a good point. Respiratory rate I have remained constant. So my compliance have actually improved, but my CO2 has gone up. So it does not mean my lungs are getting bad. It is a phenomena which has happened because my tidal volume I have decreased, but not increased the respiratory rate. My saturation has improved to 94 and BP is 110 by 70. So again, after 4 minutes, I increase the PEEP further to 12. My plateau is now 14. Plateau is again 26, by driving pressure is 14. If I have to have, I am able to come down to 50. Respiratory rate remains the same and compliance actually improves further, but CO2 remains constant. It is not increased. That's a good point. That means my alveoli are now starting opening up. Saturation is improved and BP is further improved. So what do I again do? I increase the PEEP to 14 after again 4 or 5 minutes. And then I see my plateau has suddenly jumped to 30. That means now whatever PEEP that I have increased, my lung is not tolerating it. It is causing it to be over distension. Though my driving pressure, again, if you see 30 minus 14 is 16, that has also become bad. FiO2 respiratory rate remains the same, but the compliance has fallen. That means now I'm in the upper part of the PV loop. ARDS usually happens in the lower part. That means delta V by delta P is not happening. But now I'm in the upper part, upper inflection point, where again, because of excess PEEP, my compliance has fallen. And EtCO2 has become more because of the dead space that we have created. And the saturation remains the same, though the blood pressure has fallen. The blood pressure falling again is a bad point. That means VQ mismatch will happen. So I again go back to a PEEP of 12 and keep a plateau. I see a plateau which is again gone back to the same settings. Then this is my optimal PEEP at a PEEP of 12, at a FiO2 of 50. I am able to get the maximum compliance, the lowest possible CO2, and I'm able to keep a driving pressure less than 14. So I will keep my PEEP at this setting. This will not cause barotrauma because my plateau is less than 30. So this is the graph that I have been talking to you about, the PV graph that is there. Now, if you see over here, this is the plateau, that is the alveolar distending pressure. This is the total PIP, and this is the baseline variable. Now you have to look at from a very different perspective. Now, this initial baseline part is called as the static elastic component. Whereas this alveoli, which is getting expanded with the increase in pressure, is the driving elastic component. And the upper part is the flow resistive component. This is the flow resistive component, the difference between the PIP and the plateau. Now, we are introducing a new concept over here, which is called as the power. Now, what we were earlier focused on was basically what the lung is getting, that is the plateau pressure or the alveolar distending pressure. Now, what concept new has come into the picture is how much power has to be given by the ventilator so the alveoli keep expanded. Now, this power is lost somewhere in the tubing. This power is lost against the resistance in the tubing and the alveolar distending. And this power has to work against the recoil of the lung also and the chest wall edema. So how much ventilator has to work? Now, what we were earlier discussing is how much lung is getting exposed to a pressure. Now the concept is changing and they're telling how much a ventilator has to give up power. So that is what is mechanical energy in physics. That is basically how much potential energy in the ventilator gets converted into a kinetic energy. And kinetic energy, this mechanical is like hitting the nail into the will not say coffin, I'll say wood. So this is the kinetics of energy and motion. That is the elastic and resistive forces which are there in the lung. And there is something called as the stored energy, that is the baseline PEEP. So how hard a lung gets hit is the how much power a ventilator can deliver to the lung. And that also can be calculated by formulas which are now there in newer ventilators. So they calculate the static component and the elastic and resistive component by formulas which are there in the ventilators now. Now it can be difficult to understand these formulas in your second class, but ultimately if you come down, so ultimately, the power is calculated by the peak pressure, which is there in almost all ventilators. Then the plateau minus PEEP, that is the driving pressure. What tidal volume, what respiratory rate you give, and multiplied by 0.098. Now, this gives you a particular number. If the P peak is somewhere 31, tidal volume is 90, respiratory rate is 44. So this will give you a particular number. Now, this we are telling that you have to keep this power less than 14 joules. So if you keep it less than 14 joules, that means the lung will not get hit. So we are trying to look it from a very different perspective. Earlier, what I had talked about was how much a lung is getting exposed to a particular pressure, that is the plateau pressure. Now we are telling you how much safe it is for a ventilator to give that much power to a particular lung which is already sick. So the same graphs now become little complicated. This is the graph which I taught you about. This was the driving pressure. Now they've converted this into elastic, resistive, and PEEP and made it inverted. You don't need to learn this. You don't need to remember this. They're complex formulas, not at all. But this is what we are telling you. If you have seen the movie Rocky, they are telling you how much you can hit a particular lung, and it's how much a lung can take it. So it's the amount of energy transferred from the ventilator to the respiratory system within a given time frame. It is given in joules per minute. It is calculated by the force and displacement. And it is not an answer as of today, but you should know that it is a number that you can think about. And now what they're saying is you give low tidal volume pressure, you give controlled driving pressure, you keep the plateau less than 20, but always also look at the mechanical power. So start calculating your mechanical power. And they are saying even the respiratory rate, because if you give high respiratory rate, even that causes injury. So sometimes we decrease the tidal volume, but increase the respiratory rate for CO2 to keep around 50 and 60. So we don't want you increasing the respiratory rate high also. So these are the various different ventilator supports which you should be aware of. There's partial support, which is initially in the part that can be NIV or your HFNC, then full ventilator support. And if you see at the end, again, the ventilatory support becomes partial in the form of APRV. So over here, you can actually sedate and paralyze the patient. Here, the patient will be taking mostly spontaneous breaths. And over here, the patient can be even awake. Now, there's something called as NAVA. We'll skip that. So this partial support at the end is APRV because the patient is so sick that if suppose the diaphragm starts working, negative interpleural pressure, then that will also aid in ventilation. So in a very sick patient, you might actually stop the sedation little bit and then prone. So that we'll skip this also. We'll not keep into it. Not to see the goals of ventilation. The most important goal is to provide safety and do no harm. That means earlier it was basically intubate late and extubate late. Now it is intubate early and extubate early. So optimize your VQ matching and protect the lung. That means low tidal volume ventilation. Promote patient comfort. That means adequate sedation and liberate as soon as possible. So concept now is intubate early and extubate early. Or if you're not intubating, then start using NIV and HFNC early. Now we had actually discussed this. I'll just go through it fast. This is an oxygen cascade that happens inside your body. In the atmosphere, there is 160 mm mercury of oxygen. Then in the trachea, it comes to 150. When it goes to alveolar level, it comes to 105. In arterial blood gas, it is 100. At mitochondrial level, 5. So this is the amount of PO2 that keeps on falling once it reaches the tissues. So this is just a cascade you should be aware of, that how much you are getting exposed to. I think so. We had covered this, but I'll again tell you that whenever you want to increase the FiO2 of a patient, then you have to focus on FiO2 and your MAP or your PEEP, which will increase your P alveolar oxygenation, which will increase your P arterial oxygenation. And you should be aware of this index, which is called as the P by F ratio. And if it is going below 150, it is bad. And you should know about your oxygenation index also, normally is less than 5. Then this alveolar arterial gradient is more a theoretical talk, and arterial by alveolar ratio again is more of theoretical. It is once you reach at high altitudes, if the alveolar oxygen is low, then the arterial will be low. So it's more theoretical, less of practical usage. Okay. So mostly it is the so oxygen is mostly carried in the hemoglobin, not by the PO2. So if you see, this is the formula: oxygen which is bound to the hemoglobin is the major contributor to oxygen delivering capacity to the tissue, whereas oxygen which is dissolved is only it is only 0.0003 into PO2, which is very, very less amount. So do not target your PO2s. Target your hemoglobin also, because if the hemoglobin is good, your oxygen delivery to the tissues will become better. So we don't want a hemoglobin crossing more than 10. 8 to 10 is sufficient. So what's the relation between saturation and PO2? I think so everybody knows about this oxygen dissociation curve. So if you see at the top, even if I increase the PO2 level, my saturation remains 100. Even if the PO2 goes 500, my SPO2 will remain 100. So it's of no use for me if I increase the PO2 to 500 or 340. So if my PO2 is around 80, my saturation will be around 92. So usually, if after 60, the fall in saturation will be almost linear, will be almost linear. So you should know the difference, this oxygen saturation dissociation curve. Okay. So initial small drop in SpO2, there can be a big drop in PO2. So it can fall from 500 because you do not know PO2 what was there to a PO2 of 60. But when the PO2 becomes 60, saturation is around 85. But after that, when it falls, the falls will be almost linear. So SpO2 is an easy non-invasive method. So what we are trying to say is, once you're intubating a patient, or even for non-intubated patients, your saturation target should never be 100. Because at 100 saturation, your PO2 can be even 500 or it can be 100. Your saturation target should be somewhere around 94 to 96. It should not cross 96 because it's of no advantage to anybody and it cause oxygen damage. And if it is falling below 94, you can start giving oxygen by various ways. I understand neonatology is a little bit more strict as compared to oxygen targets. If the saturation over here is falling below 94, we will start our oxygen delivery devices. So this is a simple formula for you to remember. If the SpO2 is 90 to 100, my PO2 will be somewhere between 60 and it can go even up to 500, doesn't matter. But if SpO2 is between 80 to 90, you have to just, it will be around 45 to 60. And if the saturation falls, SpO2 falls below 80, then divided by 2, you'll get a PO2. So if my SpO2 is 60, my PO2 would be 30. It's a very fixed phenomena if for the SpO2 and the PO2 relationship. And another talks that the right and the left shift is more of a MCQ. It has very less practical application. So we discussed this heart and lung, a perfect couple. We should know about cardiopulmonary interactions because the heart is within inside the thoracic cavity, and it also gets affected by the change in the thoracic volumes. So you should be aware that change in the thoracic volumes can affect the blood pressure, and this change in blood pressure can help you guide your fluid dynamics. So if you see this curve, this is the heart thoracic cavity. So in the thoracic cavity, you can see the right atrium, you can see the right ventricle, and this is the IVC, or we can say call it the CVP, the central veins blood. So PEEP over here is 0, the right ventricular pressure, atrial pressure 5, pulmonary atrial pressure will be 12. The blood is going from here to here. Now we have increased from PEEP. So this is a spontaneous breath. Now just imagine I'm taking a spontaneous breath. What happens? The PEEP actually goes down. PEEP goes down. So more blood can go inside the right atrium. So more blood goes inside the right atrium, more blood goes inside the right ventricle. It's almost giving like a volume bolus. Now this is once I'm taking a spontaneous breath. Now if I apply a PEEP of 5, now if you see the water level 5 has gone up more than the CVP. So my preload to the right ventricle will actually decrease. So instead of a negative internal pressure, somebody is giving a positive pressure ventilation, which will actually impede the flow from the IVC into the right atrium. So my right atrium volume will decrease, my right ventricular volume will decrease, and it will actually decrease the cardiac output. If it is a failing heart, then it is a good point. My failing heart doesn't require extra volume, so PEEP would be beneficial. Now over here, if I give excessive PEEP, I increase the PEEP, which is like 15 or 16. Now, what will be that doing? That PEEP will actually hinder the output from the right ventricle also. And my right ventricular dysfunction will start. So once my PEEP settings are going very high, that will affect my pulmonary hypertension. So be very careful once you are giving high PEEPs, right ventricular dysfunction will start over here. What happens in the case of left ventricle? Now this is a left ventricle, and you give it, this is the heart, and over here is the lung. So once you give an extra PEEP, now you understand this is a heart, which is a pump made of muscles. And now in the left ventricle, if I apply an excessive PEEP from outside, which will actually push the blood from the left ventricle into the aorta. So PEEP is actually good for the left side of the heart because it pushes the blood into the aorta by giving this excess PEEP. So leave the formulas. I'm just trying to tell you. Whereas in a case of spontaneously breathing patient, now here I have applied an excess PEEP of 7. Now this lung excess PEEP is pushing the heart and the blood inside the heart into the aorta. Whereas the lower diagram, now over here PEEP is -7. That means the patient is spontaneously taking a breath. Now over here the heart is not getting compressed by this, whereas actually it is getting more open. So my blood flow into the aorta will be less. So for a spontaneously breathing patient who is in CCF, PEEP will actually help by decreasing the preload to the heart, and PEEP will actually help by squeezing the left ventricle and pushing the fluid out of the heart. Another advantage of PEEP is it will also squeeze the alveolar vessel blood flow into the left atrium. Whereas if you give excess PEEP, this PEEP is going to be detrimental for the right ventricular outflow and might cause right ventricular dysfunction. So this is how a cardiopulmonary interaction which takes place. So this is just to tell you. Now this is over here is an inspiration on a ventilator in positive pressure breaths. So everywhere my heart is getting compressed by the excess PEEP. So this will decrease the venous return. So there's less of right ventricular volume because my venous return has decreased. See the position of the interventricular septum. So because the right ventricular is not getting sufficient flow, so it's mostly collapsed, but there is more left ventricular volume. The PEEP is squeezing the blood from the alveolar vessels into the left atrium, and also the PEEP is squeezing the left ventricle to push the flow out of the left ventricle. So in case of positive pressure breathing, there will be a high systolic blood pressure in inspiration. Now let us see what happens in expiration. Now in expiration, my heart is not getting compressed by the various forces in the lung. So there is increased venous return. Because the right ventricle is getting filled now, the left ventricle is less filled, whereas the right ventricle is more filled. The interventricular septum is more in the center. So there's more right ventricular volume, but less left ventricular volume, causing a low systolic blood pressure in expiration. So my change in inspiration and expiration is compressing the heart and relaxing the heart. Whereas positive pressure inspiration, the BP rises, and once I release, the BP actually falls. What is the usefulness of this? It is a dynamic marker. So more the variation which happens with ventilator, more the chance the patient might be fluid responsive. That means this patient can actually tolerate if you give more volume. Whereas if the heart is failing, there will not be much change with the thoracic pressure changes because the heart is already failed. So BP will almost remain constant. Whereas if the heart is functioning good, the thoracic pressure will actually make changes in it. So if you have a arterial BP or a saturation trace, you can see over here, the in a ventilated patient, it goes up and down. Even in non-ventilated, it can happen. But the problem with non-ventilated or spontaneous breathing is they can be breathing shallow. It will not create so much change in the thoracic volumes. So therefore, we have to give a good tidal volume for this change to happen. We'll come to that. So if you can see, it's going up and down. So this patient might be fluid responsive. You can give fluids and you can calculate your pulse pressure variation. That means what is the pulse pressure with the maximum BP, that is inspiration? What is the pulse pressure during the expiration? And what is the difference between them, PP max minus PP min by average? That will give you an idea how much the heart is going to tolerate the fluid that you give to this heart. So this, there are various, you can only calculate the systolic pressure variation. Normal is less than 10. Pulse pressure is what we defined. It is less than 13 and stroke volume should be less than 10. So if it is more than 10, that means you can give some fluid. More than 13, you can give some fluid. More than 10, that means you can give some fluid. If it is not applicable in the case of arrhythmias, it is not applicable in the case when the patient is spontaneously breathing. So misinterpretation can happen. And also if the tidal volume is less than 8 ml per kg. So in a spontaneously breathing patient, we might not be knowing how much volume per kg that patient is getting, and it will not create that much change in the thoracic volume to create a change in the blood pressure. So also there are some limitations with this. The limitations being if you give spontaneous breathing or small tidal volume, or if the chest is open, where thoracotomy was done for some reason, then it will not affect because now the thoracic cage is open, and if the patient is not in sinus rhythm. So I have discussed many concepts and I've kept it very simple, and I've tried to make it non-complicated as far as possible. So I finished in 30 minutes, but it was a two-session class. So anybody has any questions regarding critical care, lung mechanics, respiratory mechanics? So I'm open to answer and questions. You can type. So he's asking inspiratory, expiratory fold. Okay. Sildenafil help in ARDS. Okay. So, so once your PEEP is going beyond a particular region, you need basically pulmonary vasodilators. The only approved pulmonary vasodilator is a INO. Sildenafil is a poor man INO, and we don't like it. Though there are studies from DMC and few other places which shows that we can use sildenafil. Personally, we have INO and we love the INO. Inhaled nitric oxide. Okay, somebody is asking what is it? Let's stop this. I ratio. So I ratio nowadays ventilators that is also asthma, right? We had discussed this. What a second.
Sir, if questions are, can we take these questions on the group? We will close this discussion.
From my side, yeah, yeah. From my side, the topic is over.
Sir, I'll add you to a group, and those who have attended the talk can pose their questions over there.
Correct, correct, perfect.
Sure, sure. Thank you, sir, for taking out time. And it is another amazing session. Many have learned, and many will learn a lot from you in upcoming sessions, sir. Thanks a lot.
Great. All the best.
Thank you.